So welcome everyone. Thanks for coming this morning. I'm going to be talking about new urinary biomarkers in bladder cancer and how they can potentially be applicable to our practice and maybe even change what we do one day. These are my objectives. So we're going to talk about what we have right now in terms of biomarkers and diagnosis, and then we're going to talk briefly about stats because any discussion about test performance, stats are a really important part of that. Then we're going to talk about the new biomarkers that are in development and how they perform. And then we're going to try and talk about how these could potentially slot into or replace certain things that we do already. So right now, cystoscopy is the be-all, end-all for diagnosis of bladder cancer. We use it for every indication. And by and large, it performs quite well, especially given the new technologies that have come along in cystoscopy and augmented cystoscopy. But cystoscopy is not without its costs. For the patient, first and foremost, physical and psychological discomfort with having a fiber optic cable inserted up the urethra, and the non-insignificant risk of sepsis and urinary tract infection. Some estimates about as high as 2% for urosepsis after cystoscopy. As well, it's costly to the system. Probably we're doing cystoscopies in a lot of people that don't really need them, but we have no good way of identifying who those people are. And it's not a perfect test. It's very operator dependent. And sensitivity can range anywhere between 68 to 84%, specificity anywhere between 31 to 93%. And so I think there's room to improve there as well. And we have seen improvements with things like blue light cystoscopy and better scopes, but I think there's still a ways to go. In terms of adjunct tests to augment our cystoscopy, cytology is the one that we're all familiar with. Primarily, we use it to detect cancers that we miss on cystoscopy. The most pertinent ones being CIS and upper tract cancer. It's a very specific test, but sensitivity is low, between 20 to 60%, depending on which cutoff you use as a positive. Sensitivity is quite poor in low-grade disease, sometimes less than 15%. Like I said, we primarily use it to look for high-risk cancers that we're missing on cysto. And we like it for that reason because its specificity is so high. That means we have a low rate of false positives, and so we don't go off chasing tumors that end up being false positives, or chasing things that we think are tumors that end up being false positives. However, the low sensitivity also means that we miss a lot of tumors, and that's probably why the AUA guidelines at least recommend against using cytology at all in surveillance of low-risk bladder cancer, mostly because the yield is so low. It ends up just being a waste of money. Before we move on, one interesting point that I want to raise in the era of better scopes and blue light cystoscopy is that our ability to detect these hard to visualize lesions is improving by leaps and bounds. So some have raised the question about whether we need an adjunct, whether we need cytology at all, because we're getting better at detecting these things that we can't see with white light cysto. I should add that these statistics for cystoscopy that I described, those are for plain white light cystoscopy. So before we dive into talking about test performance, we have to talk about stats because sensitivity, specificity, these are all inherent characteristics of a test that matter a lot. And if you're like me and you kind of lose your grasp of that 2x2 table every couple of months, I thought this might be a helpful refresher. So here you see the 2x2 table. In the left-hand column, there are patients who have the disease, and the right-hand column, patients who don't have the disease. The top row is patients who test positive for the disease, and the bottom row is patients who test negative for the disease. So sensitivity, and you can see the equation there, is the ability of a test to correctly identify disease. A sensitive test wants to come back positive. It skews towards being positive. And that is helpful when it comes to identifying disease, but it comes at the cost of a higher false positive rate. We use sensitivity, as the mnemonic says, to rule out. Sensitivity rule out. That's the SNOUT mnemonic. And we use that because a sensitive test wants to be positive. It tends to come back positive. So if we get a negative result on that test, we have more certainty that the patient is actually negative. Conversely, specificity, which you can see the equation for right there, is the ability of a test to correctly identify the absence of disease when it's not present. A specific test wants to come back negative. So the trade-off for a highly specific test is a high rate of false negative. in this way, we can use specificity to rule in diagnoses, because if a specific test wants to be negative but comes back positive, you know that the patient is convincingly positive. So these two characteristics, sensitivity and specificity, are in theory independent of the prevalence of a population. They should be inherent to the test itself. That's in contrast to positive and negative predictive value, which are probably a bit more useful to us clinically because they tell us how to interpret a result when we have that result in our hand. Positive predictive value is given a positive result, how likely our patient is to have that disease. And conversely, a negative predictive value is given a negative result, how likely is our patient not to have that disease. And the important thing to remember about these two test characteristics is that although they're clinically quite useful, they're heavily dependent on the prevalence of the disease. And changing the prevalence of the disease can really affect the way these statistics look and can actually mask a lot of things. So we'll run through a quick example because that's a bit of... Yeah, so in pretest probability and prevalence kind of go hand in hand. And I talk about prevalence, but that kind of is a synonym for, I think, pretest probability. So we'll run through a quick example. So let's say we're looking at 100 people with microscopic hematuria, and we want to use a test to determine whether or not they have bladder cancer. So let's assume that 2% of these people have cancer of this 100 patients with microscopic hematuria. And then let's say that we have a very mediocre test with 50% sensitivity and 50% specificity. So the numbers lay out like this on the test or on the table, excuse me. So you can look at the negative and positive predictive value calculations. The negative predictive value is quite good, 98%. And that's despite having what we know is not a very good test. And that's because, regardless of the test outcome, the chance of having the disease, the pretest probability of having the disease is so small. So even if the test is positive, because the pretest probability is so low, it's more likely to be a false positive than it is, or it's equally likely to be a false positive than it is to be a true positive. So in a way, the rarity of the disease makes our shoddy test look a lot better, and it can mask a lot of deficiencies. So in this way, prevalence has a really big effect on our positive and negative predictive value. So we have to be really cognizant of that when looking at these test statistics. We need to make sure that the cohort prevalence of pretest probability matches that of what we know in the general population. Because if those are discordant, it's hard to interpret the positive and negative predictive value. This is a receiver operator curve. It's a way of graphically representing the performance of a test. You plot sensitivity on the y-axis and 1 minus specificity on the x-axis. And for any given curve, if you move along that curve, like a different test cutoff, or the boundary between positive and negative, will land you at a different spot on that curve. And in this way, people can use these curves to optimize a test for the intended purpose. You can use it to balance your sensitivity and specificity, or to favor one or the other if you want to set a threshold for your test for a specific application. The area underneath a specific curve is indicative of how accurate a test it is. So the blue curve is a better test than the red curve because there's a better area under the curve, or AUC. As the area under the curve approaches 1, the test approaches perfect. And as the area under the curve approaches the black line, which is an AUC of 0.5, the test becomes more and more useless. So back to bladder cancer markers. There are several markers that are currently FDA approved and out there and clinically available. But as we'll talk about later, the uptake hasn't really been that stellar. So this is a handy chart from the AUA guidelines. It outlines the currently available FDA approved markers, except for CxBladder at the bottom there. CxBladder is not actually FDA approved at current. And because invariably all new markers get compared to cytology, I've reiterated cytology's test statistics on the right side there. As you can see, generally, these markers that are pre-existing have better sensitivity than cytology, but worse specificity. So there are several reasons why these markers haven't really taken off. And firstly, I think it's just because they haven't been proven well enough. Most of them have only had an initial discovery study and maybe a validation study or two. As far as I'm aware, not many of these have actually been applied in a clinical setting, like in a randomized trial. And even in the few that have been validated pretty well, for example, the NMP22 here, which is the two different forms of the first test, it had 2 validation studies published in JAMA and it was quite rigorous. But as you can see, and really the second reason why these tests haven't really been taken up is that they just aren't very good. They don't have the degree of accuracy that we would need to really change what we do. They're sensitive, more sensitive than cytology, but not really so sensitive that we would be confident not doing a cystoscopy in a patient. And they have good specificity, but they still are not as good as cytology. So they give us more false positives, which leads to more unnecessary cystoscopies, unnecessary ORs. And so we still prefer cytology for that particular application. So the guidelines from 3 of the major bodies, the urological bodies, are pretty clear-cut in how they say that these markers should be used, which is not really at all. It's pretty clear that as it stands right now, these markers aren't ready for prime time. They're not ready to be a major part of the way we treat bladder cancer. Interestingly, the Canadian guidelines actually hedge a little bit, and they say that you should use cystoscopy with urine cytology or another urine marker, but don't really go much further than that. So all of this points to a need for a better test, because I think there is space to improve on what we currently do. Ideally, a better test would be non-invasive, it would be non-operator dependent, cheap, rapid, and most importantly, it would be highly accurate. Because the stakes are so high in bladder cancer, we would need a really, really accurate test to really convince us to change what we do currently. Right now, there are actually multiple products in development for different spaces in bladder cancer treatment. There are ones that are being developed to challenge cytology's role as an adjunct to bladder cancer and to help us detect tumors that we miss on cystoscopy. As cytology's sensitivity is so low, if we could have a test with better sensitivity and comparable specificity, it would be easy to see that test supplanting cytology for how it's used now. Other tests are also being developed as an adjunct to cytology. As you'll recall, cytology is reported as negative, atypical, suspicious, or positive for malignancy. The 2 on either end are relatively easy to interpret, but the middle 2, atypical and suspicious, are notoriously hard to interpret in a clinical context. And so some tests have been looked at for adjudicating equivocal cytology results. And finally, probably the most exciting application that some of these tests are being developed for is to partially replace or rule out the need for cystoscopy in patients who have low risk. So, talking about the need for a better test, well, how good does better have to be? And the group at Memorial Sloan Kettering actually looked at trying to answer this about 12 years ago. And to do so, they just asked 200 patients what the minimum accuracy of a new test would have to be to make them comfortable to forego cystoscopy. And they set the assumption that cystoscopy is 100% accurate, which we know it's not. And of the surveyed patients, 3/4 wanted accuracy of 95% or better. And the further 21% wanted between 90 and 95% accuracy. And that's in order to forego a cystoscopy. Unsurprisingly, those who had more pain with cystoscopy had a lower standard for a replacement test. So as you can see here, I think this really illustrates how tough it is to develop a new marker, because we just need such a high degree of certainty. So we're going to talk now about some of the products that are in development for bladder cancer and ones that are making their way towards the market right now. These modern markers have all the benefits of all the recent advances in molecular biology tech. Unlike the previous generation, which usually focused on a single gene or a single protein, these new ones usually have a panel of multiple targets to increase their accuracy. So there are 2 main clinical scenarios in which these are applied. The first is the hematuria patient presenting for initial diagnosis, and the second is the surveillance patient who has known bladder cancer. So we're going to talk first about patients who have hematuria who show up to your office and how these tests can possibly apply to them. But before we do that, I just wanted to talk about how difficult a space this is to break into. Ideally, these new markers would challenge cystoscopy and possibly make cystoscopy or to obviate the need for cystoscopy in some scenarios. But that's really tough, because for someone walking in with microscopic hematuria, the chance that they have a cancer is already less than 4%, right? So the negative predictive value of having microscopic hematuria is 96% already. And so there's not a lot of clinical or statistical space to improve on that. So that's a hard sphere to break into. And then in gross hematuria, the chances that a patient has a tumor is relatively high, around probably 5 to 15%. So because of the stakes involved with missing a bladder tumor, we would need a test that's very, very good in order for us to feel comfortable not doing a cysto. So now that we've talked about what these markers are up against, let's take a look at them. The first one is AssureMDX. So this is a bit of an interesting test. It actually cobbles together multiple different types of panel as well as clinical markers to maximize performance. So it's based on methylation analysis, and this is a validated methylation panel. Again, methylation is the way in which cells downregulate expression of genes, and it was found it's been previously found that methylation of these 3 genes correlates with bladder cancer, and they also combine that with mutation analysis of certain genes, FGFR3, TERT, HRAS. These are all genes that have been found to be dysregulated in bladder cancer. And then they also added the clinical variable of patient age. And this is the discovery study. It was published in the Journal of Urology in 2016. They enrolled 154 patients with no history of bladder cancer, but with hematuria. It wasn't really clear how many of these had gross hematuria or microscopic. And of these, 74 patients or 48% developed a malignancy. So based on this test cohort, the authors developed an optimized model, which they later named their test MDX Assure, or AssureMDX. The test that they created had a calculated sensitivity of 97% and a specificity of 83%. And the area under the curve was actually quite good at 0.93. However, one thing to keep in mind is that these patients, half of them had bladder cancer. And we know that of patients who present with hematuria, not 50% have, 50% is not that high. 50% don't have bladder cancer of our hematuria patients. So because the prevalence of this population was higher, it pads the stats somewhat. And this is a common strategy used in discovery studies. They enrich their populations with the disease to make the detection statistics look better. So that's something that we have to keep in mind, and something that we're going to harp on future studies as well. You can't trust this.
That's not a bad thing. It's judgment affecting pre-test probability.
Right.
Right.
Right. I guess what I should say is that you can't apply these directly to the broader clinical setting. It's more of a proof of concept than something you should take as gospel. So the year after, the same group then followed up with a prospective validation study. They enrolled about 200 patients with hematuria. They didn't collect information on cytology, so it was single arm only. Of these patients, 97% developed cancer. And in this population, the test statistics were actually quite impressive. Again, about 93% sensitivity, 83% specificity. And because of the artificially high rate of malignancy in this one, again, almost 50%, they post hoc calculated the negative predictive value and the positive predictive value for an assumed incidence of 5 to 10%. So in theory, we should be able to trust that that we should be able to trust that PPV and that NPV more. However, that's again, it's post hoc, it's manipulation. We don't really know how much that distorts things. So we got to take it with a grain of salt. The area under the curve for this test was excellent, 0.96. It's almost a 1. And the performance was poorer for low-grade cancer and low-stage cancer. But that's expected, and we'll see that's a common trend throughout all these tests. But still, the AUC for low-grade was quite good at 0.93, and it was 0.87 in TA disease, which is still quite impressive. So this is a summary of the 2 studies that we have so far. The results are quite promising. Again, it's early days. These are just discovery studies, validation studies. So it remains to be seen whether this can translate into a true clinical effect. There's actually an ongoing study of MDX Assure, or AssureMDX, excuse me, at our site. I'm not sure if it's still running or if it's finished, but the results should be very interesting to see. The next one is CxBladder. So CxBladder measures the expression levels of 5 different mRNAs in the urine. The first 4 genes have all been found to be highly upregulated in bladder tumors, and their RNA has been found to be detectable in good quantities in the urine, hence the test. The 5th marker, CXCR2, is actually upregulated in non-malignant inflammation and was included to reduce the risk of false positive secondary to inflammatory conditions. There are actually multiple different forms of CxBladder. There's one for the hematuria setting, one for the surveillance setting. We're going to be looking right now at the one developed for the hematuria setting, the initial triage, and it's called CxBladder triage. So this is the initial discovery study. It was published in 2012, 485 patients with hematuria and no prior cancer. They compared CxBladder to one of the previous generation of urine markers, which is a test based on the gene NMP22. They also compared to cytology. In 66 patients who did have a malignancy, about half of them have had high grade, which again may distort our results a little bit because we know that high grade cancers are easier to detect, and typically you don't find that high rate of high grade disease in the general population. The sensitivity for this test was 82%, which was significantly better than the other 2 markers. And in particular, the sensitivity for low-grade disease was quite good at 69%. The specificity was 85, but not quite as good as the other 2 markers. Overall, the area under the curve was calculated at 0.87. Of note, this test was only for the genetic panel. Later iterations and the ones that are actually going to market are going to, at least being tested, are actually combining genetic and clinical markers together. So after the initial descriptive study that we talked about, they developed a combined genetic and clinical test that they ended up calling CxBladder triage. And they added the clinical component to improve their test characteristics. So they added a clinical panel including age, sex, smoking history, and frequency of hematuria, and they added that to their pre-existing genetic panel and compared the 2 together. So they found actually a small but statistically significant benefit to including the clinical markers. Sensitivity improved from 86 to 95%, negative predictive value improved from 96 to 98, and area under the curve increased by 3% to 0.86. They didn't report specificity or positive predictive value here. So to date, there has only really been one discovery study of CxBladder triage, which is the one that we talked about to rule out the need for cystoscopy. The initial discovery paper actually just looked at the genetic markers, so I didn't include it here because it's not the same test. This test and other CxBladder products, which all revolve around the same genetic panel, have actually performed very well in the surveillance setting, as we're going to talk about. So they've actually moved ahead with a clinical trial that's ongoing at multiple sites in the US and actually our site here. And that's a test that looks at, it's a randomized trial that randomizes randomizes low-risk patients to the gold standard for this test to see if we can safely avoid doing cystoscopy in some patients.
That's what gold standard is.
Cysto and cytology, which is not great, but it's
So
the best one.
Also sensitivity based on cysto, like all this data is based on cysto. Based on our current.
Yes, yeah, that's right. So yeah, that's right. So thanks, Colin, for clarifying that. Basically, these tests were applied to people who are already undergoing cystoscopy and cytology, the gold standard, and so it's a comparison. Yes. So that I had a hard time finding because a lot of these markers aren't available on market. I think I'm guessing.
Usually in the
Is it? There you go.
We discussed that at the end. That's one of the biggest issues. Is how do you get through the cost? It's a number of them. Cost of the test and plus it's cost.
Yes. Yeah.
The overall
Cost is quite.
savings is
Yeah. So that's it for the triage or the hematuria setting. We're now going to move on to patients who are on surveillance for bladder cancer. And there's a bit more data in this sphere just because the risk of cancer is higher in this group, so it's easier to test your products. Again, because the risk of cancer in this population is high, it's a challenge to develop something that makes a big difference in this patient population, because if it's going to challenge cystoscopy, it has to be a really, really good test, and the standard has to be really, really high. So the first new marker in the surveillance sphere is something called Xpert bladder cancer, with this very spiffy looking ad here. It's a urine test that, again, measures the expression of 5 different mRNAs in the urine. And each of these mRNAs are associated with cellular metabolism and cell death, and are found to be dysregulated in bladder cancer. There are 2 forms of this test, one for application in the primary diagnosis setting, and one for application in surveillance, and we're going to be looking at the latter, which is called Xpert Bladder Cancer Monitor. The discovery study for this marker came out in 2017. They looked at 140 patients under surveillance for bladder cancer with an unknown follow-up time. They went the usual testing with cystoscopy and cytology, and also had this test, and they basically checked to see how many of these bladder cancers that were caught by the test. The recurrence rate was 31%, and it was a cross-sectional study, meaning they saw each patient once. And so of the patients that they saw at a cross-section, 31% actually had a recurrence, which in my mind is a bit high for what you'd expect at a single visit. The results were actually quite impressive. Sensitivity of 83%, far better than cytology, and a specificity that wasn't much worse, 91% versus 100. The negative and positive predictive values were quite high, and the area under the curve was 0.87, which looked quite good. But as we'll see, positive results initially aren't always borne out when you look deeper. The validation study published this year had a similar setup with 200 patients, again about 26% recurrence rate. But despite being a similar test in a similar population, the test performed much worse this time. Sensitivity was better than cytology, but it was still only 46%, which is less than half. Specificity was significantly worse than cytology, and area under the curve was only 0.65, which is not very good, remembering that 0.5 essentially means a useless test. So this study, this table summarizes the 2 tests we've had so far on the Xpert bladder cancer test. As you can see, the very promising initial results weren't really borne out by the follow-up study, which is a common theme. It also, I think, illustrates the dangers of implicitly trusting a negative predictive value. If you look at the second line, the negative predictive value is 83%, which might lead you to think that it's a pretty good test. But if you look deeper, the sensitivity is still less than 50%, meaning that you miss more than half the cancers with this test, which would definitely not be good enough to justify not doing a cystoscopy in a patient. And so I think that really underscores the importance of looking deeper than negative predictive value, because there are many things that can distort it.
Why is there such a disparity between the 2 studies?
So I was thinking about this myself. I don't know entirely, probably because the specificity and the sensitivity, the specificity was relatively good, so that sort of boosts your negative predictive value, and also probably because the prevalence probably had a role as well.
If you look at that, the second study had much lower protection rate.
Yes.
The first study was enriched for this group.
Mm-hmm. Yeah. Pretest probability. Yes. So this is a next test, Bladder Epicheck. This marker takes a bit of a different approach than the previous ones we've seen. Instead, it actually looks at methylation levels in the DNA of cells in the urine. So again, methylation is the mechanism by which gene expression is suppressed. And there are certain genomic loci that have been established as common hypermethylation sites in bladder malignancy. So this test is kind of interesting because it builds on a pre-existing platform that this company already has developed in cells for identification of pathogens. They sell these pre-made cartridges that you just add patient urine to, and you pop it into their proprietary machine, and it spits out a result for you based on PCR in about 90 minutes. So, theoretically, if this were to pan out, it would be very, it would be low input from the physician, and it would be easy to use. So the initial discovery paper was an abstract that was published in the Journal of Urology in 2016. 222 patients on surveillance. They compared retrospectively to cytology, and they only had partial data for the cytology. So that comparison is not a very good one. They found some promising numbers though: 90% sensitivity, 83% specificity, with 18% recurrence rate. The follow-up study was a single-arm study. Again, 353 patients on surveillance, 13% recurrence rate. The test characteristics are respectable, but they weren't quite as good as the previous study. Sensitivity was about 68%. Specificity was 88%. Of note, though, 57% of these patients had high-grade disease, which is, again, higher than we would expect in an overall surveillance population. And if you actually remove those high-grade patients, you can see that the sensitivity in low-grade disease for this was actually quite poor. It was only 52%. And this is a third study published this year, in a similar vein to the previous one. Again, 215 patients on surveillance, 69 recurrences for about 32%. This study was more in line with the second study of this marker, which showed a bit more of a modest result after the initial optimism. Sensitivity of 62%, specificity 86%, AUC of 0.79, 46% sensitivity for low-grade disease. So of the three studies I was able to find on Bladder Epicheck, the first was by far the most optimistic, and then the latter two validation studies seem to be kind of in agreement. The sensitivity, they seem to agree that the sensitivity for this test is between 60 to 70%, which is good, but probably not good enough to make us, to really move the needle for us. And the specificity is not quite as good as cytology, although it's quite good. So the last marker I want to talk about is CxBladder. It's a CxBladder product. It is the surveillance form of the test, and it's called CxBladder Monitor. They also use the same genetic panel, but then they change the clinical risk factors. So instead of looking at age and smoking history, they look at the number of previous recurrences and the time since the last recurrence. So this is the discovery study for that. They had over 1,000 patients actually, divided between development and test cohorts. They reported a sensitivity of 92% and an overall and a 85% sensitivity in low-grade disease, which is quite good. The negative predictive value was quite good at 96%. The company is pushing this marker as a rule-out test for cystoscopy, meaning that they would, ideally, if the test was negative, you wouldn't have to do cysto. And so they use that not as a justification not to report their specificity or their positive predictive value. I wonder how valid that really is. And looking at the area under the curve, which is only 0.73, with such a high sensitivity, I'm guessing the specificity wasn't that impressive. This is the follow-up study for the same test. They were actually able to accrue over 1,000 patients again. There was a 15% recurrence rate. They compared their product to NMP22, again, that older marker, as well as to cytology. In a separate patient population in this subgroup, they actually compared to Eurovision, which is another older generation test, which is a FISH, or a fluorescence in situ hybridization test. The sensitivity and the negative predictive value of CxBladder were quite good, and frankly, they were excellent. They clearly outperformed all the other tests. They didn't report on specificity or AUC, though. So this is a summary for CxBladder Monitor. Again, sensitivity looks to be quite high, higher than 90% in both of these studies, with a very high negative predictive value as well. So there's some reason for optimism here, but I think, as is the current trend for all of these tests, is that it's just not proven enough yet to really say anything concrete about how these can be used. So just to consolidate today, I just wanted to go over again the ways in which we could possibly see these tests making their way into our practices. I think a lot of these tests, although they're not proven yet, they're really on the cusp, and within the next 5 to 10 years, we might see these as a genuine option for how we manage bladder cancer. The first and most likely way in which we could see these being used is alongside or even replacing cytology as an adjunct for cystoscopy. Currently, we only really look at positive results on cytology because the sensitivity on cytology is so low, a negative result doesn't really mean much. But because these new markers have much better sensitivity, conceivably, we could actually use a negative result on these tests to influence our decision-making. Perhaps a negative result reassures us that that slightly abnormal-looking patch of bladder is benign, and we decide not to biopsy or not to resect. Conversely, a positive result and a slightly equivocal looking lesion might push us towards biopsy and sort of relieve some of that decision-making pressure. Because several of these tests also have good specificity, we could also use them like we currently use cytology to help us detect things that we can't see on cysto. Or when the test is positive but our cysto is negative, they can spur us to go hunting for things that we can't see. The next potential application would be to potentially replace cystoscopy in some scenarios. Again, like the clinical trial that's currently ongoing, we could theoretically use a negative result from a test to reassure ourselves that a low-risk patient doesn't actually need a cystoscopy at all. Or in surveillance. In the surveillance setting, we could use the test to decrease the number of cystoscopies that a patient needs or decrease the frequency. Or in the surveillance setting again, if there's a positive result in between cystoscopy, it might spur us to do cystoscopy sooner to detect a lesion. Although we didn't go into the latter two, there are also some potential applications for screening with these tests. Because they have high sensitivity and they're relatively easy to administer, we could use them for screening for bladder cancer. And although we didn't talk about it again today, there's some applications, and there's been some studies into using these tests to risk stratify people, to predict those who are going to recur, or to identify those who are recurring before their lesions become visible on cysto, just because these tests have higher sensitivity at the genetic level. So, that sounds good, and that's the pipe dream, but, how do we get from where we are now to using these tests routinely? And I think basically we have to translate this from discovery and validation studies to actual clinical trials. Like I mentioned, there is at least one ongoing that I'm aware of right now for CxBladder. But as far as I'm aware, that's the only one. And I think in order for these markers to become commonplace, there's going to need to be more of this, application to trials where we pit a test against the gold standard and see if it's safe and effective. Like I said, there's ongoing studies at UBC for CxBladder and AssureMDX, and I think the results of those are going to be really interesting. The final thing I want to touch on before I finish up is just where the field is moving. Molecular biology is advancing so rapidly that these tests that I've talked about today might be obsolete in the next few years, just because our tools are evolving so quickly. It stands to reason that our tests would evolve with them. New technologies like digital droplet PCR have exquisite sensitivity and the ability to detect tiny, tiny amounts of target DNA. That might change the field. So too, next generation sequencing allows us to drastically cut down the cost and time associated with sequencing DNA, which opens up new possibilities for ways we can develop tests in the future. And and aside from different tools, there's also different approaches to detecting cancer. One of the things that I think is really exciting is circulating tumor DNA, or cell-free DNA, which is a bit of a local specialty here at UBC. This is an up-and-coming field that likely is going to have some applicability to cancer detection for bladder. So I guess overall, I think it's an exciting time. There's a lot of potential. Not a lot has come to fruition yet, and I mean we've been here before, but I think there's a lot of potential for the landscape to really change, and I think it's an interesting time to be in cancer. And that's my talk. Thank you so much. Thanks to Dr. Black and Dr. Ashner. Unfortunately, I didn't make this morning, but they both helped me out a lot with the presentation.